All right. So if I haven't met you yet, I apologize and I have failed. But my name is Sterling Herring. I'm a physician and a researcher here at Hopkins. And I just want to kind of kick off this conversation on what we've learned and what we can do, how we can take what we've learned today and apply it to our own kind of issues at home, whatever our environment or our issues of interest. So I kind of want to kick this off with a couple of thoughts of my own, and then I'm going to kind of ask for you to chime in and say, so while I'm talking, maybe think, is there something that I've drawn out of today's conversations that I can take from their world and plug into my own? These are just from jotting down a few notes. The first thing I just wanted to share, 2 or 3. First is I'm going to have to start thinking big and small. Personally, I think big, and that's not a problem, and I really fail at thinking small. And when I say that, I mean like Rob's example in West Virginia of engaging community stakeholders, driving 3 hours to have a conversation with a room full of people to see what they're doing there and how we can support them in that. That's not something that I would typically think to do. And again, Cure Violence and their emphasis on community-based interventions, right? So all of this is very community-based as opposed to this big, giant policy type of thing. I'm a policy researcher, so I tend to think, how can we change this law? But one thing that I've taken away from today is that that's not always necessarily the best way to go about it. I want to make sure I'm having the right conversations and that I'm having them early enough. Second thing is I want to make sure I'm thinking outside of my own funding stream, right? So as Daniel so aptly put it, I was impressed with some of the multifaceted approaches that some of our panelists discussed. Some of the medical education in Michigan, that's something that I hadn't even thought about with the opioid addiction. Medical education as far as like we've put this into our medical schools and whatnot, I've heard of that. Expanding that to certain rules and regulations on CME, continuing medical education, I think that's great, kind of thinking outside of my box. And then the example of Temple University in Philly, marrying the proximate determinants to policy and saying, hey, we can do policies all day long, but we need to also expand the scope of our policy to make sure that we are facilitating success, not just mandating success. And third, as Tom put it, tireless advocacy while keeping my science above reproach. I'm going to kind of renew my resolve to not get ahead of my data, but not to give up because it's hard. I tend to stick with the latter and kind of forget the former personally, because I like the soapbox approach. But those are kind of 3 thoughts that I drew out of other people's examples and other people's experiences that I'm going to introduce into my research on opioids and motor vehicle crashes. Has anybody had similar experiences or similar thoughts that they said, hey, maybe this is somebody else's experience in a different field, but I feel like I can introduce it into my own? Eric's got the mic. Almost. He almost has the mic.
Hello, I just want to sort of echo one of Sterling's thoughts about the opioid epidemic. So a lot of what we've heard has to deal with like prescribing guidelines and things in the medical settings, but I just don't think we should forget about like the person in the environment and the systems approach and making sure that we're thinking about what's causing people to want to sort of misuse and abuse these medications. Just because as we're cracking down on prescribing, people might be more likely to move over to the heroin, and that might go up as we see the opiate prescription overdoses go down. So just to keep that in mind too.
Oh, that's a really interesting point. I've heard that called the balloon effect. As you squeeze one end, the other end gets larger. And I think that's an easy mistake to make if we're not taking that really patient-centered approach. Thanks. Somebody on that corner so that Eric can like run. We want to make sure that this is a real public health-centered event and that he's getting his exercise. Yes.
I told myself that I wasn't going to be talking as much this afternoon, but clearly that's a problem. So for all of the topics that we've talked about, both in the morning and the afternoon, in these breakout sessions, I've really been struck by how important it is to think comprehensively about these topics and sort of the multiple intervention points that the people that we heard from are pursuing, and how, I think if we're going to be maximally effective, we have to think strategically about being comprehensive with our intervention approaches. And I think it feels like that's where we're getting to in this field, that it's no longer sort of a, here's where I can intervene, here's the intervention, but rather appreciating the full context in which injury and violence occurs and the multiple opportunities for intervention and how they're oftentimes quite complementary and even necessary in order to make real impacts. So it's a challenge that I was wrestling with a lot today.
That's interesting, and thanks. And I think it's comprehensive, I think, is a great way of putting it. So Shannon and I had a conversation yesterday with someone from the Maryland PDMP, and one thing that she brought up was the difficulty of, she's like, we've got this tool. This PDMP is a potentially fantastic tool, the prescription drug monitoring program. Great tool, but sometimes our providers are telling us they don't know what to do with it. There's no wraparound, as she called it. Everything else, what do you do? Does your insurance cover care, non-opioid care? Does it cover physical therapy and that sort of thing? Do you know where to refer someone who is abusing drugs or is shopping around? And so there's all this wraparound information that it's easy to overlook that. It's easy to say, oh, we have this program, now we need to mandate this, and we need to mandate usage, and we need to mandate signing up for this PDMP. But what else? What does a doctor do in the middle of nowhere who just runs his own shop and he pulls it up and somebody's shopping, one of his patients is doctor shopping? What do you do with that? And I think that's interesting, that comprehensive thought process that has to go into these interventions. I heard somebody else talk about, and forgive me, I can't remember who it was, but somebody else was talking about the plausibility of, in surgery, having like a take-back program on follow-up. Was that you guys from Michigan? And I think that's fantastic, because where a lot of these prescription opioids coming from, I'm not going to name any names, but I know in my extended family, it's often leftovers from surgery and that sort of thing. So that's something that's been on my mind today too, and kind of look into where else I can implement that. Other thoughts? If you came in and you didn't learn anything, I'm just going to cry myself to sleep tonight. So, but please, I'm interested to learn what you learned in case I missed something, because I can only take so many notes today. Yes, please.
Hi, so I think this, echoes a lot of what's come up today, but it just constantly, to me, the idea of relationships and having sort of existing networks keeps coming up. So doing that groundwork to make sure that you have contacts in different groups of stakeholders so that when an issue comes up or maybe an opportunity for a project comes up, you already have those foundations to be able to tap into and maybe collaborate on, so that each time around, it's not scrambling to try and find contacts, build new relationships, build trust, that we already have that in place, and we're making a conscious effort to keep in touch with and stay on top of different work that's going on by different organizations and among different key stakeholders and changes that might be happening, which it seems like such a tall order. And we were talking about it at our table, what kind of time does it take to invest in making sure that all of those relationships are happening? So it's something that just sticks in my mind as something to constantly be looking out for, but recognizing that it's a challenge. So trying to find ways to do it simply and efficiently is something that I'm trying to look forward to, I guess, but I don't know how to do it. So.
Well, maybe somebody in your existing network can help you work on that, right? So.
Yeah.
So I guess the thing that I would think about is when you look at the news and when you look at what you do and just what's happening today, and you are just struck by the enormity of this problem of violence in our society and what it's going to take in terms of people and resources and funding, sometimes it just overwhelms you. But when I think of it in terms of the public health model, and I look at the success that we have had using the public health approach in other areas and how we have been successful at eradicating some diseases and making tremendous strides in others, that just gives me hope. And sometimes you just need that hope. And clearly this problem isn't going to be solved in my lifetime, maybe not in my children's lifetime, but hopefully at some point this problem is going to get solved. And just hanging on to that little bit of hope as I go to work every day and thinking about that, you know, it kind of gives me the strength to keep going. So that's what I'm leaving with.
Thank you. It's been interesting, and to me, hope is the word, I think. It's given me a lot of perspective, and it kind of rejuvenated my resolve to keep moving forward. 'Cause it's like you said, it's easy to go to work every day and get kind of worn down on what's not happening. And it's nice to look around and see some success, some innovative things that people are doing. And honestly, I'm going to be taking ideas from a lot of these people and trying them here or trying them somewhere and seeing if we can get similar results. But it's nice to see that someone somewhere is succeeding at what they're doing, even on days when I'm not. I'm really lucky. My office is right down the hall from the office of a lady named Sue Baker, who has been an early and consistent champion of injury policy and injury prevention, and the office that I'm in, for whatever, I don't know what it was used for before. Steve Tarrant calls it the Aloha Room. It's for people that are on their way out the door, so I'm a little bit nervous about that. But there's a stack of pamphlets in there that have Sue Baker's picture on there. And so if I'm sitting there and I'll just sit there and I'll be staring at the wall and thinking about whatever problem I'm trying to solve, and she really is an inspiration to me. So it's the number of lives that have been touched by her work, and it makes me think, maybe I can have a little bit of an impact. If not today, maybe tomorrow, right? So again, thank you for that. But it's hope, I think, springs eternal. Any other thoughts? If not, I think we will move on to some closing remarks from Shannon. Thank you, Shannon.
So just real briefly, I wanted to thank all of you for coming and for participating so actively. It's been, from my perspective, a great day, a great way to spend a Wednesday here in East Baltimore. So thank you for making that happen. I also wanted to acknowledge both Sterling and Eric Schulman, who you have seen running across the room many times. He's a marathoner, so we don't need to be concerned that we were overexerting him today. But both of them have just been tremendously helpful and central to really planning this day and making it happen. So I wanted to thank you both in particular for all of your efforts to make this day happen. With regard to follow-up, we will be sending out the notes from the breakout groups to people, so you'll have memories and hopefully inspirations of what was discussed not only in your group, but also in the other groups that you weren't able to participate in. You heard reference in the morning session to the revised opioid report. We're close to getting that done. And once that is done, we'll share that with you as well. So look forward to additional materials from us that are very much in line with the things that we've discussed today. Yes? Certainly, I will check in with everybody and make sure that they're okay with sharing the slides. And if they are, I'd be happy to do that. So, yep, that's a great thought. But other than that, those were my concluding thoughts, just to thank you all for being here and for your participation, and to check your email inboxes, and we'll be sending out some follow-up information in the coming weeks. All right. Thanks very much.